I'd like to welcome you all to this session. It is my pleasure to introduce our speaker for this afternoon, Dr. Stephen.
I think there's a green light here. Let me just get this. That. Aha.
There we go. Well, again, let me introduce or welcome you to this afternoon's session. It is a pleasure to introduce our speaker for this afternoon, Dr. Stephen Post. Dr. Post is currently at Stony Brook University in New York, where he is professor of preventive medicine, director of the Center for Medical Humanities, Compassionate Care and Bioethics, and head of the Division of Medicine and Society. His scholarly interests span a wide range of topics, including aging, Alzheimer's and dementia, bioethics, and the medical humanities at large. His scholarship is generally supported through both public and private funding. Dr. Post is widely published with well over half dozen books with such titles as Unlimited Love, co-authored book, Why Good Things Happen to Good People, and the soon-to-be-released The Hidden Gifts of Helping. He was the editor-in-chief of the third edition of the Encyclopedia of Bioethics, an indispensable reference work in the field. He is also on the editorial boards of several professional journals and has received a variety of academic awards and given a number of distinguished keynote lectures. Please join me in welcoming Dr. Post.
Hi, everybody. How are you? So, I was at a Presbyterian church about 3 weeks ago, and the minister was in a fairly jovial mood, and he recounted this true story of Mark Twain, who had an encounter with the Mormon polygamist. The polygamist attempted to convince Twain of the merits of having more than one wife, and Twain wasn't having anything to do with this. So in some frustration, the Mormon asked Twain, "Can you give me a single passage in the New Testament or the Old that clearly forbids polygamy?" And Twain responded, "That's an easy matter. No man can serve two masters." Just kidding. Anyway, I thought it would be good to start with, anyway, a moment of humor since you've had a long afternoon and the evening is drawing close. I wanted to take a little time to talk about the theme of compassionate care. I think many of you in your small groups, for some of those presentations, which have been excellent, but also in your larger presentations will touch well on the theme of compassion and look at it more theologically and analytically than I probably will in my presentation, but we can open up the discussion and get a little more of that. I think right now, if you ask the average person on the street, what's the big issue in quote-unquote bioethics, they're not going to say, well, should we use a feeding peg in a 90-year-old with Alzheimer's? Oh, that's a somewhat interesting question. They're probably going to say something like, well, I was in the doctor's office the other day, or I was in the hospital, and they treated me like the kidney in room 3 or room 5. I was the foot in room 8. This sense of dehumanization, of being treated like an object rather than respected as a person who is navigating an illness experience. That word respect, by the way, comes from respectara, to look twice, to look again, to look a little more deeply. I think people in clinical environments these days don't feel that their subjective experience is being treated with much seriousness, and so they therefore feel demeaned and somewhat undignified. There's a nice passage from Anatole Broyard, written as he was navigating the cancer that eventually claimed his life. To the typical physician, my illness is a routine incident in his rounds, well, for me, it's the crisis of my life. Jerome Groupman, who's up at Harvard and runs the research center at Beth Israel, had that great best-selling book, The Anatomy of Hope. He wrote in the New York Times not too long ago, the entire compassionate dimension of medicine, which is really key to the profession and which is so gratifying, all of that is threatened, severely threatened, if not erased, when you are put in an environment where you are constantly hectored, it's an interesting word, around money and efficiency and making sure that time is minimized with patients and delivering care in order to maximize revenue. It's good to hear a physician make the claim that indeed it is the healing relationship that is so gratifying for him or for her as a professional. And of course, Groupman in this case is lamenting the kinds of institutional pressures that make that care and connection so difficult. If you look at the state of medical practice in the United States these days, unfortunately, a lot of docs are alienated from medicine. They feel little enthusiasm for the healing art. In fact, 58% of those surveyed report that kind of diminution of meaning. And the vast majority of that 58%, actually almost 90% of them, say the core reason why they're not finding the art of healing gratifying anymore is because they feel the systematic inhibition of empathic care. That remarkable quality is being inhibited. Remember, Oliver Wendell Holmes said, it's not what lies before you or what lies behind you, but what lies within you. It's this capacity that we have, not to overstate it, because human nature is a mixed bag, but it's there and it's understood scientifically, and it involves everything from mirror neurons to the mesolimbic pathway. We know it's there. You can't be skeptical or cynical about it. It can be overwhelmed in negative hierarchies. But the reality is it is a big part of a gratifying experience for a clinician. Now, if you look at the literature, clinician satisfaction with their relationships with patients can protect against professional stress, burnout, substance abuse, and even suicide attempts. In fact, a study just came out a week ago in the New England Journal of Medicine saying that the most important factor in preventing clinician burnout is the clinician's ability to stay in touch with that kind of empathic element. Well, you know, in medical schools, there's a lot of mythology around the third year. Some people refer to the hidden curriculum. You've heard all this nice stuff about being a caring, attentive listener and being concerned and empathic with patients. You get into the third year when you're on the clerkship wards, and suddenly you get all this negative role modeling and everything just kind of dissipates and atrophies, and you realize that care and compassion don't mean much. Actually, that's much overstated. Our experience, and we've been studying this, is that, yeah, there can be a little period of awakening, if you will, but medical students who are trained in the medical humanities in the first couple of years and then have an opportunity just monthly to kind of debrief from their clerkship experiences actually find the challenges invigorating, and it even quickens their commitment long term to having the kinds of relationships that I think we want them to have. Resident cynicism is rampant and attributable in part to being in circumstances where they feel that compassionate care is not acknowledged, rewarded, modeled, celebrated, and the like. And of course, this is all bad news for patients. So you can look at the physiology of stress studies. A single abrupt interaction with a doctor elevates cortisol levels for 48 hours. Jeff Levin, you believe that? Jeff is here. Jeff is one of the great epidemiologists. There he is. Hi, Lee. So this is bad news for patients. We have analyses now that are quite old, pointing out that communication, the kind of tender, loving care that good clinicians are capable of, that allows patients to feel a sense of emotional comfort, and that's related to increased physical functioning, emotional health, decreased physical symptoms of pain in patients. And incidentally, just to go a little bit further on the mind-body theme, this is a study from Janet Keycolt-Glaser. She runs the Psychoneuroimmunology Institute at Ohio State University. She's very distinguished. She did a study where she took 42 married couples and she induced blisters in their forearms. And then she ran hostility scales on them. And they particularly looked at the high quartile hostiles and the low quartile hostiles, people who had a lot of hostility in their marital relationship and people who, shall we say, were relatively tranquil and at peace. Well, as she looked at the rate of wound healing, the blisters in the high quartile hostiles healed at 60% the rate that the blisters healed in those who were in the low quartile hostile category. And then she even went into the biochemistry of this and realized that it's related to cytokines and particularly to interleukin-6. And also healing rates are very much related to cortisol. Cortisol is a stress hormone. When you're in a hostile, bitter relationship, you're releasing cortisol in a protracted way, and that is not good for the wound healing system. It also causes, by the way, hippocampal atrophy, which is one of the aspects of dementia. So this is the biology of what's going on when we create environments that don't allow patients to feel cared for in the most basic sense of the term. Now, I know Jeff will be familiar with Redford Williams from Duke, a cardiologist who went back to what's called the MMPI. How many of you ever heard of the Minnesota Multiphasic Personality Inventory, right? Something like 300 questions, and it gives you an assessment of your emotional strengths and weaknesses. If you're going into counseling, including pastoral care, you sit down with a professional, and they kind of help you get a sense of your areas for potential remediation and the like. What Williams did was he picked out roughly 27 questions that he associated with hostility: hot-tempered, quick to anger, prone to violence, uncompassionate, unforgiving, and the like, and he called this the hostility scale. Now, this thing's been delivered widely in the United States since the late 1930s. So he looked retrospectively at people who took the test when they were 25 years old, and it was 1950. And then he asked, what's their circumstance 25 years later in 1975 when they're 50 years old? Well, the high quartile hostiles had a 20% death rate, and they were mainly dying of vascular disease, again related to cortisol and the dumping of fatty acids into the vasculature system. The low quartile had a death rate of about 2%. So this really changed the whole face of American cardiology. When I was a kid growing up, people said, you want to avoid heart disease, don't multitask, don't have a type A personality. You ever heard that? Now they don't say that. Here's what you want to avoid. After we finish up this evening and you're driving out onto the highway and the person in front of you has the audacity to stop at a yellow light and you fall full-breasted on your horn and yell out an expletive, then you got a problem, okay? It's the hostility. It's not the fact that we're kind of doing too many things and have a little bit of a New York strut. So the key thing then is that this loss of compassion in contemporary medical care, which so many patients identify as a point of significant dissatisfaction, it's very bad for the patients, and it's very bad for the clinicians, and the medical students, and the nurses, and everybody else. So what do we do? If you walk into Mass General Hospital in Boston, you look up on the left wall in the foyer, and there engraved in stone are the famous words, actually the most often quoted words in all of American medical history, and they come from Dr. Francis W. Peabody in a famous address that he gave to the graduates of Harvard Medical School in 1925, and a couple of years later it appeared in the Journal of the American Medical Association. Basically, the secret of the care of the patient is in caring for the patient. And of course, also Peabody gets into a kind of mind-body dynamic where he says, all of you have had experiences that have brought home the way in which emotional reactions affect organic functions. So, what about being compassionate? I do think that in the end, it is something of a matter of choice. I guess I'd say I'm enough of an existentialist to believe that the world is a much better place when we really do simply take responsibility for how we interact with it. I know that sounds a little bit naive, but it's terribly important to claim the space for compassionate care, no matter how challenging the environment might be. It takes a lot of effort, a lot of self-awareness, but again, at some point, we just have to accept that kind of responsibility and focus and make it a big part of our lives. Caring with an added level of empathy gives rise to attentive listening, the sensitive use of words, etiquette, attention to the details of comfort, and respect for patients. Oftentimes you'll see in the medical humanities novels, or you'll view movies about doctors who have been pretty brutal and cold with their patients, but suddenly they've had to grapple with a severe diagnosis in their own lives, and that allows them to kind of turn the corner, and it changes the way they practice. Well, it shouldn't take such a grave event for clinicians to move into the world in that kind of a compassionate fashion. It should be something that we can develop, that we can elevate in education and in clinical environments. Now, you look historically, there's that great prayer attributed to Moses Maimonides. I say attributed, no one quite knows for sure whether Maimonides wrote this, probably not. But anyway, it's on the walls of a good many doctors' offices. May my love of the art of medicine inspire me to seek at all times to expand my knowledge and to see within each of those in need only the human being. And Jack Coulihan, one of my colleagues at Stony Brook, a great clinician, poet, well known to many around the country, in a recent article in Annals of Internal Medicine, spoke about the humility involved in being compassionate. You have to have an unflinching self-awareness, a sense of your emotional limits and how to manage those. You have to work at empathic skills, at attentive listening. And it all has to do with gratitude. Ultimately, Jack says it's about attitudes of gratitude. Cultivate on a daily basis as a spiritual discipline an attitude of gratitude. I'm grateful for the privilege of caring for sick persons. I had the honor of being a friend of Cicely Saunders for 25 years. And the last time I saw Dame Cicely was in 1999 when she came to a conference that we held at MIT on empathy, altruism, and agape, a symposium between science and theology. She was giving the evening plenary address. Now, for those of you who haven't been familiarized with Dame Cicely, she originated the hospice movement worldwide. Before Dame Cicely Saunders, there was no such thing as a hospice. In fact, she invented the modern use of the terminology. See, in the ancient world, in the medieval period, a hospice was just some place where a traveler going across the hills of Europe might spend the night. Perhaps it would be associated with a convent or some such thing. And she used her analogical imagination, and she said, dying is a journey. And so she appropriated the word hospice. And of course, when she founded the hospice at a time when a lot of people felt that it was somehow unseemly and even unethical to die without a tube in every orifice, natural and unnatural, she was bucking the trend, but she was brilliant. You know, she was able to network well. She always said, there's nothing special about me, but I'm just able to bring other people into this kind of a vocation. She also often said, you know, people, it almost sounds like a comment from Martin Luther King. She said, people are really interested in what I did. I founded the worldwide hospice movement against tremendous opposition. I'm in all the nursing books and the social work books and so forth for having achieved that goal. But she said, the one thing they're not interested in is why I did it. And then she said, I did it because God told me to do it. And if you go to London and you look in the Christian bookstores, what you'll find are whole shelves devoted to Dame Cicely Saunders. So when she gave this evening address in 1999, October 99, you know, I just remember it. She said, I'm 83 years old and I can't retire because I feel a calling from God. It was almost Pentecostally language, although she was an Anglican. She said, I'm 83, I still go into St. Christopher's Hospice every morning, and I do a fairly menial task, but I do it with the right heart, she said. I'm prayerful about it. I change bedpans. And then she said, after I do that for an hour, I just sit on the ends of the beds of people who are dying. Because she said, the greatest human need, especially when you're dying, but she said more broadly, is the need for significance. My life has worth. It doesn't rest on some cosmic mistake. And she said, when I listen attentively to people who are dying, they always feel loved. She said, there's something about listening attentively to people that makes them feel loved in the agapic sense. And that's the kind of person she was. She said, after I do that for a few hours, then I get into fundraising and public relations and all the other kinds of things. But she was an amazing woman. And when you were around Dame Cicely Saunders, it was phenomenal. It was almost Pauline in the sense of this sort of composite of virtues. She had a clear inward freedom. She had a joy that wasn't just happiness. You know, the happiness researchers talk about genetic set points and dispositions. But happiness is completely subject to surroundings and environmental circumstances and the vicissitudes of life. But with Dame Cicely, it was like Mother Teresa, you know. It was like Jean Vanier. There was a joy in her that wasn't subject to externalities. It really just welled up from this incredibly wonderful relationship that she claimed she had with God, who had called her to do her work. And she had a wonderful sense of gratitude. She had a hope that wasn't just optimism, but it was a hope. You know, hope is a virtue. You cultivate hope through hard times. Hope has to be tested. Optimism is just, again, a dispositional set point. But she was so hopeful and always so joyful and so serving and so caring. She was an amazing woman, and I just am amazed at her life. When she died about 4 years ago, some of you may have seen the op-ed pieces and the obituaries in the New York Times and elsewhere. Well, they were about as long as your arm. What a life she had, and she really changed the world. You know, she would always echo with Helen Keller or Mother Teresa, there are no great works of love, but only small things done with great love. So it's all for her, she said, about affirmation and connection. Whenever you approach the patient, it's your responsibility to affirm and connect. That's what you're there for, and that's what makes them heal. Now, it is true that from some evidence we have, female physicians are a little more likely than male physicians to be engaged in these kinds of healing emotional interactions. That's certainly the case. I have a clinician friend who runs the palliative care unit at Stony Brook, Lynn Hallerman, and she's really fascinating. She stops with all of her students behind her as she comes to every door, and she does an exercise called stop, knock, breathe. She stops, you know, she concentrates a little bit on what she knows about the patient behind the door. She knocks, waits for an answer, an invitation to come in. She'll say, "May we come in?" And then if the answer is yes, she breathes and they enter. She wants to be self-possessed. She wants to be under a kind of emotional control. And when she comes into these rooms, there's a buoyancy about Lynn that really does make patients feel good. And one of my mentors back at Case Western for 20 years was Joe Foley, who was the head of neurology. He's now 95, he's emeritus. He'll define that, by the way, as emeritus without merit, except you get free parking. But Joe had a residency student years ago by the name of Joe Martin, and Joe Martin became the dean of Harvard Medical School. Joe Martin retired about 4 years ago, and Joe went to the retirement, of course. I was invited and enjoyed the event, and Joe recounted something. He said, Joe Foley was the president of the American Neurological Association, and there we were, a bunch of young interns trying to get our licenses in neurology, and we were following Joe around. And you know what we remember most? When Joe would walk into a room, he always knocked. And then, even with people who had neurological difficulties, whether they had mild dementia or stroke or whatever, he always got down, made eye contact with them, called them by name, even if he wasn't sure that they would be able to respond. And then he would ask them, after he laid a hand on their hand, he would ask them, is there anything at all that I could possibly do to make your stay in this hospital more comfortable? And Joe Martin said, this one woman who'd had a mild stroke, she said, yeah, I'd like a cup of iced tea with lemon. And Joe Foley went out and made sure that that was delivered, right? So that's the important thing. When you think about it, I guess there are really two ways of living in the world. Buber anyway thought so. So there's I'm the center of the universe. The world, the planets revolve around me. I relate to other people only insofar as they contribute to my agendas. And then there's thou. I discover the other is other. I'm not the center of the universe. And this kind of deep, affective, emotional transposition from I, it to I, thou is so key. It's great for the people around a clinician, but it's also, as I've already mentioned, very good for clinicians themselves to stay in touch with that dynamic of their lives. There's a little phrase in Psalm 11:25 that I like, those who refresh others will be refreshed. I'm not a dualist. I think that this is a two-way street. I think when we live generous lives and cultivate the right kinds of healing relationships, it's extraordinarily good for the agent as well as the recipient. So how do you create? This is the great challenge of healthcare reform. Everybody's talking about healthcare rights and so forth, about computerized medical records. I do worry sometimes about medical students. When I go back 22 years ago, when I first started at Case Western, a lot of our medical students, they had very, very good interactional skills. They read the fine nuances of facial expression when they did patient interviews. Now we have lots of medical students who are just looking at the computer and not even making eye contact with the patient because they're so busy typing this stuff in. And it's like there's two realities, right? There's the reality, of the patient right there who can be touched and related to in a way that affects everything from immunoglobulin A levels in saliva to oxytocin levels to brain release of serotonin and dopamine. If you're just really there in an attentive way. On the other hand, if you're just caught up in this sort of parallel universe, it's very hard to make the kind of connections that we associate with compassionate care. We need healthcare systems that teach compassionate care, that expect it, that model it, that acknowledge it, that celebrate it, that reward it. Everybody has to view themselves as models of compassionate care. That's so key, and that includes the CEO, it includes the parking valet. A lot of times when patients report dissatisfaction with a clinical experience in our oncology center, our cancer center, it's because, somebody in the parking lot or some receptionist somewhere just said something that was totally cynical or disrespectful. So we need to really be attentive to the seamless context. And this needs to be a process that involves physicians, students, residents, volunteers, the whole 9 yards. We need to bring this into all hiring processes. What we're doing at Stony Brook is having a required orientation for all hires at all levels, and we put the new docs in the same level as the new people who are making the food or who are even collecting fees for TV use in the rooms. They all go through the same orientation on compassionate care. And it's actually being quite well accepted, and it's making a change in the culture. If you look at these kinds of curricula, and they are emerging around the country, they always begin with the voices of patients because, just in terms of the epistemological vitality of these programs, when you hear patients tell the stories about how they felt dehumanized, how they felt that they were treated without an ounce of respect or dignity, that is the kind of starting place that we need to begin change. Simulation centers, we teach our students to ask very simple questions. Things like, this must be pretty tough, right? How are you handling this? Do you need some help? Just small things. You must feel overwhelmed by this, yeah? It doesn't take a lot. Whole universities now have mindful communication programs, like at the University of Rochester, where they use meditation, self-awareness, prayer, didactics, and so forth, and they're focusing in on the dynamics of compassionate care. Around the country now, there are 750 hospitals that have weekly Schwartz rounds. There's a website, theschwartzcenter.org, up in Boston, which disseminates all kinds of material around the country, but it's really great. It's not focused on medical outcomes, it's just focused on how was that patient treated on the kind of existential relational level. And this is a very, very important thing. Bottom line, viability, institutions that embrace this new approach to compassionate care enhancement do better vis-a-vis other systems. It's very hard to compete these days without practicing patient-centered care. And here's the amazing thing. This is really interesting. Some people say, this is inefficient. Actually, if you look at the studies, I can give you 20 studies on this, all right? So if you take the time, just like Joe Foley did, is there anything I could do to make you more comfortable in this hospital? Iced tea, yes, okay. It doesn't take, this is a half a minute, right? When you have these brief interactions, which are almost symbolic, but they do a whole lot emotionally, then first of all, you get earlier and more accurate diagnoses because patients are more willing to divulge things about themselves when they feel that kind of emotional safety, and you don't have to probe so hard for them. And of course, there are lots of things that you'd never imagine asking, but they will just be sort of routinely forthcoming because a person feels relaxed and comfortable and emotionally at peace. We know that in today's American healthcare system, 1 out of every $3 goes for what we'll call medical non-adherence. 10 years ago, we talked about medical non-compliance, but the language game has shifted. Non-adherence, people not taking their medications, not following their doctor's advice, stopping their antibiotics, not doing their immunosuppressants, et cetera, et cetera. 1/3 of every dollar in the American system goes for essentially remedial care, if you will. And what is the single factor that in many, many studies almost assures good patient adherence? It's a single factor. Whether the patients feel compassionate care, not from, the nurses and the social workers, not delegated, but from their doctors, okay? And this even affects wound healing. So, Toby Cosgrove is the president of the Cleveland Clinic, which does more heart surgery than any clinic in the United States. And Toby wanted to know what was getting people out of the clinic faster, and of course healed. I mean, nice caveat, healed, after major heart surgery. And what he found was that those patients who reported compassionate care from their physicians, directly from their physicians, were getting out about 20 to 30% faster on average. And then you go back to Janet Key-Coke-Glaser and begin to realize, oh, wait a minute, cortisol and interleukin-6 and stress, these things are all related to the healing process. There's actually a physiological benefit on an outcomes level when you treat patients with tender, loving care. That's really something to remember. So this is not a loss. And by the way, in terms of time, it takes no more time on average, several studies show, to interact with patients in a caring way than it does in an abrupt and unkind way. So what's in jeopardy? This is a comment from Ed Hollowell, a pediatric psychiatrist at NYU, who had a best-selling book recently. What's in jeopardy in medicine for a host of reasons is the human connection between doctor and patient. There are doctors in training now who do not want to do the physical exam. They just want lab tests and the echocardiogram on a heart patient, for example. But the laying on of hands is a powerful tool in establishing trust and healing. If the healthcare profession would rediscover the power of human relationship, we could bring about the kinds of lifestyle changes that would reduce disease big time. Let me tell you that in the Southern Medical Journal, just 2 months ago, Candy Brown, distinguished professor at the University of Indiana, PhD, Yale University in religious studies and psychology, published an article that was based on the work of a Pentecost healer named Heidi Baker, who works in Mozambique. And very controversial article because of the responses to it. But what I think Candy showed very well is that it's that attentive presence, the touching, and so forth that really can make a significant difference. You know, in the whole New Testament, as far as I'm aware, there's only one example of what you'd call distance intercessory prayer healing. But it's all filled with the touch, right? And we know biologically that when you touch someone, it relates to oxytocin levels, to vasopressin levels. It has all sorts of biological impact. So there's something we need to learn about the fundamentals of a healing relationship that we're forgetting. So I'm just going to show you a picture because it's worth 1,000 words. This is a gal I met in Idaho once at the governor's conference on Alzheimer's disease. And you know, the deeply forgetful, they lose that temporal glue between past and present and future. But actually, as Gil Meilander pointed out this morning, you know, there are different kinds of rationality. There's the how-to rationality, right, that the Enlightenment philosophers emphasized and that too many bioethicists emphasize, right? I'm a person if I can project plans into the future and operationalize them. That's the how-to rationality. But there's also the who you are rationality. So I remember once going into a nursing home in Ohio called Heather Hill, and I spent the day with people in the advanced care unit for Alzheimer's. I read the little biographical sketch on the wall of a guy named Jim, and I found Jim and I sat him down and I asked him, "How are your 2 boys?" Well, he couldn't respond to me at all. His communication system wasn't in great shape. But he had a twig in his hand. And he took that twig and he put it in my hand. And when he put that twig in my hand, there was so much buoyancy and energy and love and just palpable happiness in that guy. I couldn't believe it. I mean, if love was electric, that unit would have been on fire. So I gave the twig back to him, and then lo and behold, again, these are people, he had severe Alzheimer's. He walked in a circle and he picked up the dirtiest rag doll I think I'd ever seen. It was a little puppet doll, bear doll that you'd put on your hand. You know, you probably got one of these when you were a little girl. My daughter had one, you know. And this thing looked like it must have been 100 years old. And he picked it up and he actually brought it over to a woman who was whimpering in a corner, and he placed it on her lap and he walked away and she stopped crying. And I asked the nurse, "So what's the story with Jim's twig?" And she said, "Well, he grew up on a farm and he loved his father very much. His father was a Christian and he really invested a lot of tender, loving care in his son. His father gave the boy one chore every morning, which was to bring kindling in for the fireplace. And like about 1/3 of the deeply forgetful, Jim was living back in that time that he most associated with tender, loving care, in this case from his father. And because symbolic rationality, as they're now talking about in the neuroscience literature, really stays deep into the disease and probably never really dissolves, right? So he was associating that twig with love. And so there, in the midst of the deepest forgetfulness, we saw the power of love at work, and even the power of joy at work. And I think that's important. So the most recent study that you all probably saw in Nature was about memory, dementia, and music. People who were in severe Alzheimer's disease, who may not have uttered a word for 6 months, who have just been down there in a chair drooling, right? You approach them with the right affect, like Stephanie does here, that sort of, joyful buoyancy, and you sing a song that you know they remember from an earlier time in their lives, right? And 2/3 of these people in the advanced stage of dementia will chime in, and oftentimes not just for a word or two, but even for a verse. So my point there is, think about the deeply forgetful with compassion, with respect. Look twice. Don't ever assume that they're gone, absent, husk, empty, right? But recognize that there is still, as Gil said, a person underneath all of that. And I have seen it, I worked for 20 years with the Alzheimer's community. I've seen it time and time and time and time again. My definition of hope is be open to surprises. Never discount the possibility that individual will somehow, after a good night's sleep, early in the morning, be able to respond with a degree of insight. And now neuroscience is actually looking at this. They're looking at this scientifically, and they're finding it's not just anecdotal, it's actually quite a common experience, even a majority experience. So we need to always recognize the connection between dignity, between looking for the personhood in people, even when the glass may be half empty, and the job of compassion, of connection, of acceptance, of affirmation. That's our work. So Stephanie was a great example of that. I'm going to wind up here just by saying that, these days, you almost wonder if this kind of pro-social dimension of life is so good for doctors and for all of us. Should you recommend it to patients? I did a study with Maria Pagano a few years ago on the 12th step in AA, and it's amazing. If you look at people who go dry day one and you follow them for a whole year, the ones who have fulfilled the 12th step, and we had various measures for that, that means helping other alcoholics by visiting them in the rehab units, by maybe visiting them in prisons, by making the tea or coffee or being a greeter at the door at an AA meeting. Those people have a 40% recovery rate. 40% of them are sober 1 year after they go dry. If they do everything else in the 12 steps, but they don't disinhibit, a la the 12th step, the human capacity to serve others, their recovery rate is only 22%. So the New York Times ran a headline article on this. You double the likelihood of recovery from alcoholism in a 1 year window if you help other alcoholics. So Bill Wilson and Dr. Bob had it right? They understood you couldn't overcome this addiction if you didn't reach out and help another person who's suffering from your problem. We have studies of MS patients, Carolyn Schwartz at Harvard. You take MS patients, subjects, and you give them a compassionate exercise to call MS patients in the control group just 3 times a week, brief, compassionate phone calls. How are you doing? How are you feeling? Is there something we can do for you? And if you follow those folks for 2 years, the ones who make the calls have all these benefits in confidence, self-awareness, self-esteem, lower depression, and higher role functioning. I'm going to end here in just a minute. As far as healthcare professionals go, there are beautiful studies coming out now. So healthcare professionals, okay, they get in these intense environments and they're pressured, they're hectored about the finances, as Groupman points out. If they break out of it, they just break out of it, and they do missionary service for 2 weeks in South America or Mozambique or whatever it is, right? They come back and they take these same burnout scales, and they're actually much better off, and then they continue to improve at a 6-month window and then at another 6-month window. So when you allow people to get back in touch with the real reason why they went into the healing arts, which is to be caring and generous and giving, they do better. Finally, I just want to mention the helper is high, which is old news, but it's worth noting. If you have individuals at low thresholds who go out and work in the soup kitchen or just help a neighbor for a couple of hours a week. Half of them will come back feeling euphoric mood, which is now associated with epinephrine released from the brain. 43% feel more energetic, 28% feel warm, 22% feel calmer, less depressed. The calmness is now associated with the release of oxytocin, which in behavioral endocrinology is associated with compassion, social trust, and tranquility. Doesn't that sound just like your image of a saint? Social trust, compassion, and tranquility. And there is a biological basis for it. Not to reduce it to that, but it's there. And yes, 13% felt a reduction of aches and pains. There are two reasons for that. One is, helping another person distracts your attention from your aches and pains, but there also is a biology of this that is endorphin related, because the endorphins are natural palliative chemicals that the brain produces. That's why you get high on opiates. I'm going to wind up here. Abraham Lincoln said famously, "When I do good, I feel good. When I do bad, I feel bad." There was a great biography of Lincoln that came out not too long ago called Lincoln's Melancholy. And it talks about how his friends had to have a 24/7 suicide watch for Abraham Lincoln at the age of 21. This went on for several weeks because he was so melancholic, so depressed that they feared for his life. He'd actually fallen in love with a young woman, and she had passed away due to a sudden infection. This was something that was very hard for him to take, and he'd lost his mother and then his sister, who more or less raised him for a number of years, to sudden infections. And how did Lincoln handle this? Well, he determined three things. He determined, first of all, that he would stay alive, despite these hardships, because there was something that God wanted him to do to serve others. So he emphasized that, and he said that he determined to have patience, and so that eventually that will for his life would be revealed. Can't go into the details of this, it would take too long, but suffice it to say that there are wonderful stories about Lincoln in Washington, D.C. after he left Springfield, where he'd been for so many years and raised his family. And of course, big moves are painful things. But he'd be seen, he's already 6'4", and he'd have a big top hat, and he'd just be unescorted out in the streets of Washington. He'd go to Union Station, he'd find a young gal to help because she had a big chest to get on the train and she could never lift it herself. And he just did these pro-social, generous, giving things all the time. He also used mirth very purposefully, and he wrote letters to folks who had lost loved ones in the Civil War. Beautiful, brief, but wonderfully articulated letters. All this was his way of giving. But in that process of giving, he said many, many times, he found his own redemption. He found his own recovery from the depression that plagued him all of his life. It's interesting, the last day of his life, his wife, Mary Todd Lincoln, who had some issues herself, said in the morning Abraham was in the most buoyant mood imaginable, but then in the afternoon he had become cloudy and dark. So we just need to recognize, and I won't go into this at length, just how important it is to our health to disinhibit this altruistic capacity and to contribute to the lives of others. A final little study that came out of Berkeley University following 300 preteens, 12-year-olds from the Bay Area from the 1920s. About 1/3 of these kids indicated generous pro-social motivations in life at age 12. I want to do something with my talents to help humanity. If you follow them over the course of their lifetime, psychologists, clinicians follow them every 10 years, the ones in that third have lower depression rates, they score higher on happiness scales. And if you look at who's alive now, they're in their 90s, and this was recently done. 2/3 of the people who are still alive come from the 1/3 of those who, as 12-year-olds, had an altruistic, giving, call it generative attitude in life. So, in other words, when we can acculturate our kids through church work and whatever to this kind of giving, although this is not foolproof, obviously, and these are just statistics, and any one case is one case, but as a gross generalization, it's good to be good. So I'm going to wind up with that, my message is compassionate care is really important. It's good for clinicians. It's great for patients. And it's something that we probably, as we move forward and evolve in the 21st century toward a more spiritual vision of life, I think that we'll find more recommendations. In the Bay Area, incidentally, there's now a big research project going on. They are recommending to geriatric patients that they be involved in volunteerism at a threshold of several hours a week. And they facilitate for the older adults, because we have all these studies showing that older adults who are involved pro-socially, after you take away all the baseline health factors and so forth, they're actually happier, less depressed, living longer, and so forth. So that's my message. It's good to be good. Those who refresh others will themselves be refreshed. Thanks. And one big caveat, as people come up, I don't want to make this sound like self-help. It's not. I mean, these are all just scientific generalizations. You've seen one case. So the benefits of giving, St. Paul wrote, God loves a cheerful giver. Attributed to Jesus is the passage, "'Tis better to give than to receive," and that echoes through St. Francis of Assisi and through The Merchant of Venice and into the writings of Harry Stack Sullivan. I want to say that obviously our primary intent is to help others, but as a byproduct or an after effect, or as Catholic moral theologians would say, right, as a secondary effect, the fact that there's a good likelihood that we will flourish as agents is really important. It doesn't always hold that way. You can be overwhelmed, you can be in situations that are entirely dysfunctional and the like, but as a general rule, when we get in touch with these capacities, we benefit. And it's good news in a time when, when I was at Case Western, the one time I got a call from the psych unit, I'm not a psychiatrist, I'm not an MD, it was because there was a kid who was under suicide watch in the university hospitals, and he was a 19-year-old kid. He was from Cincinnati, Ohio. He had gone through most of his freshman year at college, and obviously he was deeply depressed because he was obsessing about the negative aspects of life, but he was incredibly smart. He had written a paper on Sartre, the look. So anybody who even looks at you with kindness is just trying to manipulate you, right? And he had read The Selfish Gene, which basically tells you that even if you think you have generosity in your heart, you're just the unwitting conduit of these DNA replicators who are using you to move themselves into the future, right? And he had read all of these things, it's fair to say that a lot of the second half of the 20th century didn't just take a skeptical view on the authenticity of human compassion, but was downright cynical. And that has had its after effect. But what the new science is showing with the mirror neurons and with all the dynamics of empathy and altruism that we're beginning to understand is that this is very, very real. And even the Darwinians have come around. So, 20 years ago, all the Darwinians were into individual selection theory. I'm competing against Jeff for some beautiful object in the environment, Leah. Okay, something like that. But now, the Darwinists are talking about group selection. They say, actually, and Darwin pointed this out later in his life in The Ascent of Man. He said, a lot of evolution occurs between groups. So group A does better vis-a-vis group B if group A evolves within itself a whole lot of helping and altruistic and compassionate emotion and behavior and tendency. And if it does, and the suggestion there was that this would be so internalized that it would be salutogenic, it would be health related at some level. Of course, it doesn't get you to a shared humanity because you could still have in-group, out-group conflict, and maybe the big role of philosophy and religious thought is to get us to a shared humanity, to a sense of a common destiny. But the point is that you can no longer be as skeptical and cynical as, say, when I was a boy growing up and high school in New Hampshire when, we read the territorial imperative and we read all these things, and you just sort of had this feeling of existential malaise. I mean, if there just was no goodness in human nature and there was no goodness in the universe. It's funny how the existentialists first attacked the goodness in human nature and then they went after God. Yep.
Thank you very much for your comments, and I was just very happy to hear everything you have to say, because the focus of my work has been the meaning of illness from the perspective of the person who is living with illness. And one of the things that I have always known that is so important is that it's very important for the physician to provide compassionate care. So I'm very happy with everything that you said. One question I do have is, you made the point that you worry about medical students because now they don't want to do physical exams, they're focused on the computer. And what I'm wondering is, with this kind of emphasis that you are giving to them, does it enable them to develop an empathy themselves, as opposed to simply another technique?
Another technique. Yeah, that's really interesting. And by the way, I don't want to make any gross generalizations about today's medical students. I do think that they're on a steeper learning curve when it comes to their ability to communicate effectively with patients. When I compare today's medical student with the student I knew 20 years ago. And I'm not sure what to attribute that to, but it just may be the fact that they're so focused on this kind of parallel universe that the real universe of connection doesn't quite have the fullness and the palpability that it deserves. But we do a lot. I mean, we approach it. We have 80 hours with these students in the first year, and 42-hour sessions with presentations of really good material in these areas, and then we do small groups. We do a lot of simulated interviewing kinds of activities. And I will say that the residence directors who take our students are reporting back that in response to the question, would you take these students again? They say yes, because they have a real good ability to communicate with patients. And there is a study that came out of NEO-UCOM, Northeast Ohio Colleges of Medicine, a couple of years ago, pointing out that you want to do two things. You want to have lots of medical humanities in the first couple of years. You want to have that third-year scenario where the students have an opportunity in an threatening environment. So they're not with their clerkship directors, but with some small group leader who they may know from the second year, right? So I do that, for example. And when they can just keep a journal of the good modeling and the not so good modeling and talk about it, that gives them a resilience. And then they just sort of bounce back, and they actually have more resolve. They realize that the world will never be perfect. I talk about a seamless system. You'll never really have it. It's sort of an impossible possibility or something like that. But they do gain a resilience, and it can stay with them. And you need to approach it not only in terms of medical humanities, so they need to be reading, William Carlos Williams, and they need to be reading Chekhov's Misery and all those kinds of things. They also need the science, because when you can connect science and compassion with clinical outcomes, and also with their own well-being as medical students and then clinicians long term, right? Then they take it seriously. I'm sorry about that. I wish it wasn't so, but that's the case. They take things seriously when you can, put it up on a PowerPoint, or when you can say, there are these studies published in Science, right? Then they get serious about it. And then the other thing, ultimately, you have to model it. So I do believe that with all the humanities, which is sort of a form of exhortation, with all the science, in the final analysis, it's about generativity. It's about passing the torch from one generation to another. I'm a big advocate of pay it forward, not pay it back, so don't worry too much about don't let the law of reciprocity, tit for tat, hang over your neck like some sort of Damocles, but be free of it and just hope that by acting in certain ways, you will influence others to go and do likewise. That's my favorite passage when it comes to the theology of love in the New Testament. Go and do likewise. You may not ever see that happen yourself, but just have a faith that some of the people you interact with will really take this to heart. Like Joe Martin took what he saw from Joe Foley to heart and went on and became the dean of Harvard Medical School. So it does work, but you have to do it with sensibility, and it helps a lot. You can't just do it with philosophy. You have to know the sciences. You have to approach it at a mind-body dynamic so that folks can really capture the power of this and not think, oh, it's touchy-feely. Just touchy-feely. Yeah. Anyone else? Please.
Thank you for your remarks. I too get concerned about the thought that such things can be understood as a technique. It strikes me two comments that may be worth your while.
Please. Yeah.
One is it seems interesting that medicine, which is so overrun by technique and technology, is one of the few professions that still has an apprenticeship, namely residency, which that apprenticeship begins to really take effect in third-year medical school in most curriculum. And there was a comment by one of the hearers last night that reminded me of a passage, I believe it's in the Tacit Convention, but it's Foley saying that in these complex behaviors that they cannot be transmitted by prescription because no such prescription exists. It can only be transmitted from master to apprentice.
Yes.
And that then the apprentice, he would go on to say, would indwell that.
Right.
Which is a way out of this understanding of, oh, here's the technique, you do this and this and this and this and this.
Yep.
You do those things so that people will incorporate them, then move beyond them. The second...
Yeah, I totally agree with that point, by the way. I think in the end, it's the modeling, it's passing the torch, it's the Aristotelian notion that really matters.
Or I'm thinking Hawkins, the just man justices.
Yeah. So these behaviors are not taught didactically, but they're transmitted from person to person. Yeah, absolutely, 100% with you.
But a quick second comment. I was struck when you were talking about Dame Cicely that she chose hospice, similar to hospital and hospitality from hospice, which has that polysemy, or one might say ambiguity, much as the Greek xenones or xenos for the hospitals of the early Christian Empire, where the word means not just stranger, but guest, and it also means host.
Right.
So it has this remarkable ambivalence, so that ultimately xenophobia is at least as much fear of playing the host as it is fear of the stranger.
Yes. Yeah, I agree. I mean, just on that point, I think the word hospice, it goes right back to the Hebrew biblical notions of hospitality. And isn't it interesting if you think about the origins of Judeo-Christian moral thought, that this idea of hospitality to the stranger is so key. I read Robert Putnam's Bowling Alone, or his new book, American Grace. And, so many Americans are on the move. De Tocqueville said, in 1837, in Europe, people die where they were born. In America, someone's just built a house and barely got the roof on, and they're off someplace else, And we don't remember sometimes clearly enough how difficult the experience of uprootedness can be, and what it really means to be a stranger and the sort of depth of homelessness, if you will. And there's a whole epidemiology about this. You know, when you look at it, I mean, there are, you know, depression rates, adolescent suicide rates. I mean, there's a downside to this kind of mobility because, you know, we are people of place. We're like trees. We need roots. We need familiarities. So we need to be careful about this. And therefore, you know, if you get right back to the origins of Judeo-Christian ethics, it begins with this idea, have a special heart for the traveler. Have a special heart for the person who is on a journey, because they may really be suffering in ways that you can hardly even imagine, you know. And I know that, having moved from Cleveland after 20 years, raising a family, all my friends are, you know, the parents of the kid on my soccer team or my daughter's team, you know. And suddenly you come to a new world, and what goes on there, you know, it takes a half a year or even 2 years to fully overcome it and just to kind of get back on track. So I think that the whole notion of hospice and hospitality has a moral and theological depth that we need to think about much more seriously than we do. And for Dame Cicely, you know, I mean, the hospice was a place to care, right, for those who were on a journey. Yeah.
Steve, talk a moment about how you think that this model of giving compassionate care challenges the idea of the necessity of caregivers to keep some sort of affective distance.
Oh, yeah, so this is a really good question. So, you know, how does this relate to the importance of keeping some kind of affective distance? Yeah, so listen, I mean, you go back and you look at the address that William Osler gave when he left the University of Pennsylvania in 1880 something or other and went to Hopkins, and it's called equanimitas, right? Which means, you know, staying balanced, the virtue of equanimitas. All this crazy stuff is coming at you in a clinical context, and you've got to stay cool, right? And if you look at that famous essay, it's one of the most famous essays ever written in American medicine. It's all about detachment. And Osler emphasized detachment, but then if you actually look at the writings of Osler on bedside ethics, you know, it was all about proximity, about connection, about attentive listening, and so forth. And there's a woman, an MD, PhD named Jody Halpern, who's written a book about detachment and empathy in modern clinical medicine. It's out with Oxford. And it's a very good book because what she says is basically allopathic medicine overdid the detachment thing. It so emphasized detachment and objectivity, the over-objectification, the over-biologization. You know, that's the biological slab on the bed there, right? And don't think for a minute that, you know, the quality of an interaction is going to have an impact on a biomarker, right? And I think you know what's happened now is that with all the big transformations in American medicine, people realize actually detachment isn't necessarily the way to go. Now there have to be boundaries, and I mean no question about it. I mean, you know, healthcare professionals need to know how to just walk away and smell the flowers. They need to have balance in their lives. They don't want to be overwhelmed. The last thing we want to do is overwhelm these capacities. But the point is that if we can find that balance, then people live much more gratifying and much more successful professional lives. So the detachment thing is objectification is important. I mean, we know when we train medical students, what's the first thing they do? They get a cadaver, right? I mean, that's actually kind of ironic in a way. I mean, the other approach, which Case Western did years ago in the early 60s, everybody comes into medical school and they immediately have a patient assigned to them, right? And usually a patient in family clinic or something like that. And they follow that patient and they go through a childbirth and they follow the child for 2 years. I think that, you know, we need, even at that level, we need to think about what it is that we're trying to impart to medical students, you know. I mean, we just hope they don't treat all the patients for the rest of their lives as cadavers, right? But I think but the dialectic between affirmation and connection on the one hand and detachment on the other is very subtle. And it needs a lot of attentiveness. Yeah. Yeah. Hey.
Thanks. Since I'm wearing my Oxford tie, which says Equitas,
Ah.
I thought I'd try to redeem Oxford just a little bit.
Yeah, well, I wasn't putting it, I was just saying, I was giving balanced view.
Because even within the essay,
Yeah.
even within
Yeah.
the essay, because I found it very instructive. I used to actually, as a medical student, didn't wear my Oxford tie because I thought it meant detachment until I read the actual essay.
Yeah.
And in it, Oxford says that the way you get to the point of equanimity is by recognizing the foibles of the patient, foibles not unlike your own.
Ah.
And I think that that's a valuable insight that I took as a clinician and redeemed Osler enough on the idea of equanimity that I started wearing at the time, which I was instructed to wear and was disobedient until I read the essay. And just as
Good.
a second
Great.
point to a previous point, I had never made the connection before, but I'm very intrigued by talking about hospice and care of strangers and hospitality. There's a Swedish philosopher of medicine named Frederick Linnaeus, who was taken from Heidegger, a wonderful term that he uses sort of the primary experience of illness is Unheimlichkeit, the experience of not being at home in oneself.
Yes.
So that in that sense, every patient then becomes a stranger for human care, who's without a home even within themselves. I just
Yes.
think
Oh, no,
that
that's-
useful for
That's really good. And the Osler thing, I'm fine with that. I think that's right. And I'm not trying to give the great Osler a raw deal. So I take both points with delight, Dan. So thank you very much. And I'm glad you're wearing your tie. It's actually a pretty nice looking tie. I got to look at it a little more closely later. Where'd you get it?
these are given out to everybody who trains at Hopkins and medical service, where most of the work is most of the time. I'm supposed to wear it on Fridays. I left Hopkins a long time ago, but I still wear it.
Oh, that's great. I love that. That's great. Any other comments? Are we thoughts? Okay. Thanks. Oh, yeah. And you all got a little 3-ply brochure on an actual master's degree in compassionate care, first of its kind. Thanks. It's been fun. Appreciate it.